Okay, so today we're going to talk about the neurological exam. Good afternoon to those who are joining us. The lecture is going to start with a quick case. An individual who is seen in the United States, Western United States, who had an isolated arm complaint. He was triaged as an arm injury. He noticed sudden onset of shakiness while he was lifting weights. He denied any injuries. He had no history of similar symptoms. The symptoms were isolated to his left shoulder, his left arm. He didn't have any headache or vomiting, no history of stroke. He did have a distant history of leukemia. On exam, he had no pain to the arm, but he had an exquisite intention tremor that had pronounced dysmetria. He was unable to engage in finger to nose, and he said that the symptoms started about an hour prior to coming in. So, think a little bit about what the differential is, and the next test you would have ordered is we're going to jump right into the learning objectives. We're going to just describe kind of how the neurological exam changes management. It's probably one of the more complicated components of care when it comes to actual uh, assessments of our patients. And we say that because a neurological exam is just extremely complicated, and one one lecture is certainly not um, an exhaustive overview of this, but it is going to be kind of just a quick overview in terms of how it can actually help you assess the patients that you take care of, and also determine any clinical diagnoses that you might be able to make without any actual imaging studies or potentially um, other testing. So, uh, neurological exam starts with a mental status exam. Uh, we almost always exclusively do this first. It's an exam that basically has an order in which you need to actually do it. The mental status happens first because it dictates kind of the remaining portion of the exam. Cranial nerves are usually second, followed by motor sensory exam, reflexes, and then coordination of gait. Um, Usually gait is tested last, mostly because some of the patients who might have a altered mental status might not be able to walk, or gait is usually one of the things that is tougher for older or acutely ill patients. So, how does a neuro exam change management? Neurological diagnoses, especially those that are made both in clinic and in acute care settings, are usually clinical. So clinical correlation is almost essential, even if you are going to order a test. Trying to assess a patient for seizure is not usually something that you would want to assess unless you witness seizure-like activity. Same thing goes for stroke. You would want to order imaging on somebody that you weren't otherwise sure potentially had negative symptoms suggestive of stroke. So usually you can order tests as much or as heavily as you want, but the the fact of the matter is that almost all diagnoses made through neurology, both in clinic and in the hospital, are almost always requiring some degree of clinical correlation, i.e., most of the diagnoses are in fact clinical. So, in low resource settings, when you don't have testing, it's essential to be really good at a neurological exam, which is kind of how we landed on this topic. So, important circumstances. You guys wanted to talk about altered mental status a couple months ago. We had a quick talk about that, but I hope that this kind of also goes without saying, and that I have harped on this enough. When you're talking about evaluating a patient with a neurological exam, you want to make sure that you have some clinical context, and the most important clinical context is the vitals. You want to make sure that the vitals are obtained first and foremost, and that any vital sign abnormalities are corrected before you assume that any type of neurological symptom isn't related to vital sign abnormalities. We're going to talk a little bit about neurological emergencies, but It goes without saying that most neurological emergencies can be secondary to certain vital sign abnormalities, i.e., hypothermia, hypotension, anoxia, hypoxia, all of the above, respiratory failure. So, mental status is always the first part of the physical exam, but you want clinical context and you want to make sure that you obtain vitals before you actually do a mental status exam. Well, the neurological exam is something that you can kind of assume a order for. You also want to make sure that you have different approaches for different patients. I do a different neurological exam for somebody that I'm evaluating for stroke than I am evaluating for intoxication. So clinical context is extremely important in that regard, and make sure that you're evaluating the complaint. If the mental status obscures your exam, then you want to make sure that the altered mental status is fully evaluated in certain ways, that you have some degree of understanding of what you're potentially concerned about, why the patient is altered. Are they intoxicated? Are they seizing? Are they postictal? Are they stroking? What tests do you need to order in order to try to suss this out? It's okay for a patient to be undifferentiatedly altered, and if that's the case, you just need to be very comfortable with doing the exam that you've created for yourself for an altered mental status patient. This is a non-exhaustive list of neurological emergencies. It's kind of meant not to be daunting, but to give context that there are several etiologies that are, in fact, related to vital sign abnormalities. I would expect shock states to have vital sign abnormalities. I would expect a number of different things, severe hypothermia, uh, heat shock, all the pretty substantial neurological syndromes definitely also have associated vital sign abnormalities. If they don't, then you want to start looking for things that are on here that are listed on here that don't necessarily have vital sign abnormalities and might cause a focal or a profound global deficit. Um, and that's just something to keep in mind is that vital signs create clinical context. So the first part of the exam is mental status. It can be a very detailed exam or it can be a very abrupt exam. Usually my mental status exams are abrupt. Um, I will say I don't necessarily go into detailed mental status like a psychiatrist might, um, but we're going to talk a little bit about that. Usually, the mental status that we use in the emergency department, at least in the United States, is the GCS. Um, you guys know the GCS. Lowest score is 3, highest score is 15. This is just for your context, as verbal, motor, so um, are the incorporated components of it. Remember that this was only actually validated back in the day, back in Scotland and Glasgow for TBI. So just know that the GCS of 8 that we always assume for trauma does not always mean intubate the patient. It only is validated for people who can't protect their airway in the setting of a traumatic brain injury. It's not even validated for all sets of trauma. Usually, this actually just implies that if the patient has a TBI and the GCS is less than 8, the risks outweigh the benefit to persevere into at that point. So just remember this is not something that always is the case for shock. It's not the case for toxicologic ingestion. It's not even the case for stroke usually, but we do end up using it for stroke. Um, just remember that GCS less than 8 does not always necessarily break in the airway. So that's just an important component of mental status. When we're talking more about kind of the detailed components of a mental status exam, we talk a little bit more about orientation and thought process. Cognition is something that can be difficult to test, but is something that is part of the mental status exam. Usually, the 4 components of orientation for our exam in the emergency department is just asking orientation to time, place, person, and situation. Thought process, these questions are basically trying to assess um, how the patient is thinking through certain things. Orientation gives them a perspective of where they are in time and space. thought process is kind of what is the past, what is the future. So it's a little bit more complex. Usually, orientation kind of assumes that they have some type of intact mental status that they can answer all four of these questions coherently. Thought process can be a little bit more difficult, and usually a patient with a neurological complaint, whether it be weakness, whether it be motor sensory discoordination, anything, will have maybe some deficit to the thought process. So usually this isn't tested in the emergency department. Cognition, same thing. If someone's coming in for confusion and their primary concern is confusion, uh, they might have discoordination with their inability to cognitively function. And if that's the case, you can answer some basic questions. You can assess for attention, which is part of cognition. You can also just ask very simple questions like how many days are in a week, whatnot. It's always important to know a patient's baseline. So if you're assessing a patient's mental status, you want to make sure that their collateral, their family, whomever might be whomever might be available can give you a little bit of context about what their baseline is. Um, we also want to make sure that we also want to make sure that you adapt your mental status exam based off the patient's education level. Um, it can also be tough sometimes to recognize that speech is not actually part of a mental status exam. Speech is tested separately, but it's an invaluable portion in terms of trying to assess a patient's mental status. It's almost impossible to evaluate somebody's mental status without speech. You can ask them to follow commands. This is usually what I do, is I will document specifically if the patient's able to actually move all four extremities to command. If they are altered, then you can also make sure that you're actually asking them to answer the questions appropriately, or engage in some degree of conversation that might take some thought process. It might take some cognition. So um, just keep that in mind. A diminished mental status is seen in a lot of different conditions. It's probably the most common neurological complaint is altered mental status. So if you don't have a mental status exam, uh, you you want to make sure that you're checking vitals. You also want to make sure that you're evaluating for focal deficits. This usually implies that I do exactly what I had mentioned earlier. I ask the patient to move all four extremities. I ask them to follow commands to all four extremities. If they're able to do that, then I ask them to follow commands to specific cognitive processes. Show me a thumbs up, show me two fingers, touch your finger to your nose. And if they're able to do that with all four extremities, but they're still altered, then the list of things that you're thinking about becomes shorter. And that moves the needle in terms of your pretest probability. You want to make sure that you're evaluating for positive and negative symptoms, i.e., weakness, hyperreflexia. Reflexes are an important part of the neurological exam, and they actually become more important when the patient is altered. So we're going to talk a little bit about that, but we want to make sure that we actually have a neurological exam when the patient is altered. And if you don't have said exam, we can kind of talk a little bit more about that. But there's some implications uh, to evaluating for focal deficits when the patient's altered as well, because it changes what you're thinking about. You want to make sure that you have a good history and that you're calculating out risk factors for these patients as well. In the United States, we talk about a neurological triad, which just implies CT scan, EEG, LP. For a patient who's just altered, a CT head is usually the standard of care. And the reason why is we're mostly concerned about hemorrhage. The component to hemorrhage that the commonality of intracranial hemorrhage is great enough that we want to make sure that we evaluate these patients with a CT scan pretty quickly, pretty emergently. It prognosticates the patient's altered mental status, but it also creates a situation where we can actually offer them treatment if there is a neurosurgical intervention that could be offered. Um, Usually, I would say, anecdotally, CT scans are more for prognostication than for anything else. But so if a patient comes in and they are altered, you want to make sure that you're asking orientation questions first. That's kind of the thing that I do in terms of I can eyeball a DCS from the door of the room. So if you walk into a room, I want you to get very comfortable with being able to just say, this patient's GCS was 13 when I walked in. Um, it's pretty dependent on how often you do it. So if you just ask yourself that, if their GCS is 15, then I ask orientation questions. If they can't answer orientation questions, then I ask them to try to move all four extremities. Um, and if they can't do that, then I'll kind of evaluate for what they're doing in terms of localization, if they're posturing, if they have any reflexes in a specific area that are of concern. And if they're not necessarily doing that, then I'm doing things like corneal gag, cough, things of that sort, because this patient is in trouble if they don't have any localization, they don't have any posturing. Um, you know, given the appropriate clinical context, even an intoxicated patient should have cranial nerve reflexes. So if they don't, then you're kind of concerned about something more insidious, more serious, and it's probably not just intoxication you're dealing with. So kind of a four step by step thing. So first you ask the orientation, then you try to evaluate for any focal deficits by asking them to move all four extremities. You see if they're localizing, you see if they're posturing, and if they're not doing any of that, then you want to see if they have cranial nerve reflexes. So what are the cranial nerve reflexes? Cranial nerve exam is extensive. You can do it in a number of different ways. Neurologists do it a little bit different than ER doctors, I will say. Um, you know, my knowledge about the cranial nerve exam is really about these specific ones. Um, and this is all I do in the emergency departments, and I'm only ever asking really about visual fields, about extraocular movements. I'm asking the patient to smile. If they have a sensory complaint about the face, then I'll ask them to see if they can actually feel me when I touch. Um, Unless they have a hearing complaint, I don't usually evaluate for hearing. But the easy way to do this is to just rub your fingers together on both sides of their ears and see if they can actually hear the same thing. Um, there are other ways to do it with the tuning fork. I don't know if anybody knows how to do that, or if that's part of their practice, but there is a way to do that. And then, if you want to evaluate cranial nerves 9, 10, and 12, you ask them to lift their tongue, and then you ask them to say, ah. Um, Isolated cranial nerve exams or isolated cranial nerve deficits are common and they do happen in certain conditions like botulism. They happen in something called Miller Fisher variant, which is a type of Guillain-Barré syndrome. Um, they can be common in trauma too. People can have isolated trochlear nerve palsies. Um, they can have, you know, isolated neurological deficits involving the cranial nerves. What I will say though is that the cranial nerves correlate to a specific area of the brain. So if you're concerned about what something is potentially going on and there's a specific portion of the neurological exam that's leading you to believe that they have some type of infection, inflammatory response, something that you can't see on a CT scan or an MRI, and you want to try to localize the lesion, a cranial nerve exam is extremely helpful because it will help you correlate with what area of the brain is potentially at risk. Um, like I mentioned, there are certain syndromes that you want to be able to recognize: myasthenia gravis, multiple sclerosis, intranuclear ophthalmoplegia, optic all these conditions that can potentially present as isolated cranial nerve deficits. So, uh, as one of my old instructors used to tell me, anatomy is power. If you have a good understanding about where the cranial nerves are, and you notice a deficit, and you're concerned about an isolated lesion, then it can give you some degree of understanding of where the actual lesion would be. Um, if you have a patient that's unresponsive, my go-to is usually a corneal reflex. Corneal reflex assesses um, on the next slide, the corneal reflex assesses the optic nerve in its relation to the oculomotor nerve. The gag reflex usually tests um, the hypoglossal nerve and the vagus nerve, as well as the glossopharyngeal nerve in circumstances that's involved as well. The oculocephalic reflex just basically means that you turn the patient's head and evaluate for any correction that they might have with their actual ocular motor nerve. Um, a normal person will try to actually keep gaze looking up. If they have what's called the doll's eyes, which just basically means that they're not correcting with any type of saccade, that it implies some type of brainstem injury. Um, the cough is pretty self-explanatory, but that's the vagus nerve that controls that. And then there's the masseter reflex, which is something that I don't regularly do, but basically it just means that someone clenches their jaw when you move their jaw forward. And you stimulate the masseter reflex through the facial to the trigeminal nerve, or trigeminal facial. So, moving forward with the cranial nerves, once you're done with the cranial nerves, usually what I would do is I'll do a motor exam. Motor exam can be extremely detailed. It can also be extremely brief. Like I said, if the patient's chief complaint is altered mental status, then I'll usually just ask them to move all four extremities. It's an extremely valued skill to be able to actually move and have strength. So usually people are pretty aware when they have these deficits. Um, we talked a little bit about the cranial nerves. Um, for the upper extremities, I don't do more than these things. Um, these things just control my pretest probability about spinal etiologies. They correlate with specific areas on the actual cervical spine as well as the lumbar spine. Um, if you can do all four of these, or if you can do all of these actions, then as far as I'm concerned, your each spinal level is intact. Um, if you can't move a specific extremity, then you get more concerned about like a central cause. I.e., if you notice pronator drift, or if the patient has focal weakness in each leg, that makes me think more CAT scan of the head rather than MRI or CAT scan of the spine. Um, you know, just remember that each distribution does come off the spine. And if you're noticing some weakness to the arm or to the leg, think about spinal etiologies as well as the. But this exam will kind of help you gauge whether or not you're concerned about the spine or if you're concerned about strength. Um, your Ouija of an arm should make you think about stroke. You have like isolated inability to grip strength, flex your elbows, extend your elbows, things of that sort, and you want to think more about spine. Motor exam is tough sometimes because the patient needs to be able to actually follow commands in order to do it. So if the patient has altered mental status, there are ways to assess strength. Usually what I do is I try to actually pull on patient. What I'll do is I'll sometimes fit my finger into their hand, and then I'll pull, or I will assess tone. That's the other way to kind of gather whether or not they have any neurological weakness. If you move their arms and they don't have any tone, it makes you think more of a structural or etiology suggestive more of negative symptoms. And the motor weakness that you have from stroke can be spastic, but it can also be it can be hypotonic. So if you notice that they have flaccid tone, um, more so on one arm than the other, then you should be thinking about doing a CT scan to evaluate for vulnerability stroke. Uh, the sensory exam is pretty complicated. When you get down to it, it's also pretty simple. You just got to remember that the nerve roots come off the spine, but that they're also controlled by the brain, right? So, um, sensory exams usually mostly just distribution. You just need to remember where it comes off the spine. Um, I have to look this stuff up sometimes. Really, The only way that I evaluate the sensory exam, though, in the emergency departments, I usually just ask the patient if they're having any paresthesias, and if they're not, they can feel it when I touch their four extremities, then I move on. Um, this one's one that's very important to remember, that metabolic etiologies are certainly something that can cause sensory deficits. So hypocalcemia, hypokalemia, hyperkalemia, hypomagnesemia, all those things can definitely cause sensory deficits. So just remember that. Usually my workout for sensory deficits in the emergency department is blood work. I usually defer imaging unless they have other focal deficits. So sensory exam doesn't move the needle very much. So for a responsive patient, reflexes are usually focused based off the patient's presenting complaint. If they come in with arm weakness or leg weakness, then I certainly will test the reflexes of that extremity. Um, under usual circumstances, I'm testing isolated limb complaints, I'm testing coordination, I'm testing strength, and then I'm testing reflexes. Um, you know how to check all these reflexes. Hoffman sign is something that is infrequently done though. That's the Babinski sign of the arm. Basically, what you do is you take their hand, you flick their middle finger. I'll make sure to actually add a video of this one, but it's basically an assessment that's comparable to the Babinski, but of the upper extremity. In a patient who's unresponsive now, reflexes become way more important. I will say that I actually test reflexes on patients who are unresponsive more often than patients who are responsive, mostly because the exam is a little bit more focused. But once the patient becomes unresponsive, testing reflexes actually is a huge part of my exam. So, are they altered? Yes, no. If yes, then you want to see if they can move all four extremities. If no, then you want to kind of move on to this, and you want to see if they have cranial nerve reflexes. You want to check their pupils, which is something you guys know how to do. Um, you want to check their corneals. You want to check their gag reflex. You want to check their cough reflex. And you want to remember where those areas are in the brain, in what order they might end up diminishing in somebody who is either intoxicated or very, very critically ill. Um, Remembering the difference between decerebrate and decorticate posturing is also important. Just a little reference here for that. Uh, um, Cranial nerve reflexes are extremely important though when you're evaluating a patient who's unresponsive. I think that I put them in the order of importance, but I think people's first, and then check corneal reflexes, check a gag, and then if you can assess for cough. Usually this is kind of only doable when the patient's integrated. I check out their cephalic reflexes only if I'm really kind of like concerned that they might be brain dead. Coordination. So when you're talking about assessing coordination, there's dysmetria, there's ataxia, and then there's dystonic cohesion. Those are kind of the areas of coordination that we talk about. Most coordination is essentially processed through the cerebellum. Remember that the cerebellum is ipsilateral, and it is usually something that coordinates to that side of the body. The right side of the cerebellum controls the right side of the body. There's something called an intention tremor that you see frequently with people happening in the lower extremities or the upper extremities. It usually implies that there's some degree of deficit to the fine motor skills that you have when we talk about actually using our arms and our legs um, to coordinate fine motor movements. Coordination is usually just assessed through finger to nose, heel to shin, um, and we do this just by asking the patient to take their finger, touch their nose, and then extend it all the way out to the shin area, all the way out to the clinician's finger. Full extension is the most important thing to remember about this. When you talk about heel to shin, you also want to make sure that they draw their heel all the way up to the knee. If they don't, then you can miss fine motor weakness. You can also miss very subtle dysmetria. Just that kinesia is usually just assessed in patients who have inability to rapidly alternate their extremities. If they have true just kinesia, you really want to think about like a cerebral disease, but also things that localize to the basal ganglia. Usually dysmetria, the first next step test is an MRI. If somebody has something very, very frank or something very, very obvious, like the gentleman in our case, CT scan can be sufficient. Coordination, different than balance. When you're talking about balance, you're talking about assessing for ataxia. There are certain things that affect balance that cause imbalance or ataxia, and those are actually different things than what causes dysmetria. Usually, when you talk about a true imbalanced state, you're talking about pretty substantial diseases, things like posterior reversible encephalopathy syndrome, one keys, toxic cerebellar dysfunction related to drugs and related um, other agents that can potentially cause cerebellar toxicity. Usually, it's very easy to evaluate for imbalance, though. You ask the patient to walk. If they can walk, but they feel subjectively imbalanced, then I usually ask them to tandem gait, which just basically means that they put their toes towards their heels and they walk along a tightrope. So, why does this matter? If you don't have a CT scan, a neurological exam is all you have. Usually, this basically implies that you need to feel very comfortable with diagnosing a stroke clinically. Um, I, in all honesty, have never diagnosed a stroke clinically solely outside of Tanzania. I don't do that in the United States. I usually have readily access to a CT scanner. But if I need to make an assessment and um, make clinical judgment skills based off of starting a patient on aspirin or talking to a neurosurgeon without a CT scanner, I would feel comfortable doing so because I feel confident in my neurological exam. Um, you got to remember that there are like several things that make a big difference in terms of neurological care. I think the first is probably aspirin. Second is antibiotics. The other things are things that you might not have readily available, like a neurosurgeon or ventilator. Um, but just try to remember that a lot of the neurological conditions that we're talking about actually just require supportive care, supporting the respiratory status, treatment of any underlying infection, and then certainly treatment for any thrombotic or embolic phenomena with aspirin or anticoagulant. Generally, neurological emergencies have a pretty straightforward approach. You're going to do primary survey. In addition, you want to do vitals. You want to make sure that the general exam follows a certain flow, and that you have a focused exam for every specific or every specific neurological complaint that might suggest. My exam for altered mental status is very different from organ weakness, and it's incorporating components that will actually determine my pretest probability for other conditions. Really quickly, stroke, two types. You know this. Remember, if you want to focus on preventing the injury, so create a circumstance where their vitals and their sodium and their glucose and their metabolic status is all normal. Remember all the stroke syndromes. I think we talked about this a couple of months ago. This is just a very brief list of toxicants that cause neurological symptoms. Uh, Usually the treatment with benzos. Um, for a sedative hypnotic, you want to make sure that you have a ventilator available. And there you go, so know how to do OPs. So, uh, just remember that if they're concerned about infection, this is something that's done. Um, I think the most important thing is that the way that this can be missed is if the patient doesn't present with headache or fever, but instead they present with hypermental status. Vital signs are vital. If the patient's hypothermic and the present is altered, it can be easy to dismiss this, but usually I do a lumbar puncture on these patients if I don't have a clear understanding about why they're otherwise altered. Um, so, don't fall back on a procalcitonin and don't fall back on a white cap. Just do it if you feel like it's clinically indicated. Um, I'll also, one of the other things that I will frequently do is if I don't have a good understanding about why patient might be hypoglycemic. Hypoglycemia is also a common presenting uh, presenting complaint for meningitis. So just remember all the things that incorporate into later stages of meningitis because you want to make sure that you're actually not missing it because it can present in a number of different ways. So I know that you guys know how to do LPs. I also know that you guys probably don't have access to an EEG or an MRI machine regularly. Um, these tests are available, but they're not always really indicated for a lot of conditions. I would say the one that is the most common reason for an acute care setting is the MRI of the brain. And we talked a little bit about why it would potentially be more helpful in dysmetria. It's just better at seeing the cerebellum. Other than that, CT scans are usually sufficient. So um, MRIs are things that you potentially shouldn't necessarily feel that you need to order on a regular basis. Hopefully, the CT scan is usually feels sufficient. So, in the individual at the beginning part of the beginning part of the lecture, he had a intraparenchymal hemorrhage that was causing his symptoms. This is representative of a scan that looks similar to his. Um, he ended up having a stroke. We transferred him. They did non-operative care. His GCS remained 15. Um, while the GCS is just a number that we can use for intracranial hemorrhage, it's important that you remember that they trend. And if his GCS were to decline, then neurosurgery probably would have offered him an intervention, or he could have potentially been a candidate for ventilatory care slash intubation if the GCS got low enough. So that was the case. Just in summary, make sure that you're doing your exam consistently, and that you have a specific exam that follows the pathways in terms of altered mental status, in terms of weakness. If there's ever any concern about, getting better at a specific part of the exam, feel free to reach out to me and we can talk about it. But the neurological exam is very, very difficult and complicated. It can be kind of one of those things that you just have to practice really, really frequently and get better at. I still feel like I struggle with it sometimes, um, and practice makes perfect. So we're going to talk about obstetrics next month. That's going to be in June. I'll send out an invite to that, and I'll make sure that this gets posted on YouTube and KOPI's website. So look out for that. I'm gonna stop recording. I think a lot of people we had some attrition in this one. So it's great talking to you guys, and I'll talk to you next time. Thanks.